Okay, so I want to talk to you all today about how Yuvo actually partners with our FQHCs in order to promote value-based care. And this partnership is really important. At the center of our partnership is data. And so we're going to walk through our Yuvo ecosystem and how it integrates with all of the different data points that are needed to be successful in value-based care. Okay, here we go. So when we talk about our flywheel here, the Yuvo flywheel is really driving collecting and coalescing data and then getting it to the point of care. So as we talk through this, you will get this theme of using data, getting it to the point of care throughout everything in this conversation. So we start with our interoperability, and what this really means is that we are connected to all of the health networks out there, through Care Quality, eHealth Exchange, HealthX in New York, and then Commonwealth. And what this allows us to do is not solely rely on claims data, which can be quite lagged. It allows us to collate non-FQHC data as well and bring that in-house. And then next, what's also important for us to be able to do pre-visit planning, post-visit conversations, provider education, and a whole host of other things is EHR integration. So Yuvo has actually built their own Yuvo APIs. We call it lovingly Yappy. And this is integration that we have today with Epic and ECW, and that's primarily what we find FQHCs on. But we are completely interoperable with any other EHRs as well. And here what we see is that we're direct connected to these EHRs, are able to identify when our patients are coming in so that we can work with the providers on pre-visit planning, using that data that we just talked about, and then serving it back out at the point of care, curated so that when the patient walks in, the provider sees the latest and greatest information on that patient. So of course we take all this data and, we have to coalesce it into something and pull together analytics. We use some of our own proprietary models. We also use Johns Hopkins to come up with, what are the best patients that we should be working with based on being high cost, high need, or other factors that are raising the total cost of care and allow our FQs to be most aware of who they need to manage, those with a lot of ADTs, a lot of discharges, unplanned events, or recidivism back into hospitalizations, as an example. This allows us to really partner closely with our FQHCs in the data that we share back with them. And I actually touched upon this a bit in the prior one, but we talk about risk stratification in that aligning the patients so that when they're coming in, the provider has the best information. Imagine patients are coming in and the provider knows nothing about them, or the last visit they had was 18 months ago or a year ago. This allows the provider to be keenly aware. And more than the provider, it also allows schedulers and others within the clinic to be aware. So this risk stratification is really important to understand the severity and acuity of those that need to be managed in this patient population. We also work with the FQHCs to do outreach, to drive patients in and to get them to their preventative screening. So drive them in to be seen for annual wellness visits, wild child visits, and then also to go get their, colorectal cancer screenings or their breast cancer screenings. And we do this in partnership. We say, okay, here's a list of patients based on our stratification that need to be screened for a variety of things. Let's work together, whether it's postpartum, they've recently had a birth discharge and we need to get them seen. We work with the FQHCs to make that happen through text messaging and other methods of digital outreach. Calling as well is another way that we outreach to them. We also use care navigation today via Switchboard Health, but otherwise we may use our internal services as well. We have care navigators that do outreach to patients to, again, say, you were recently discharged as an example, and let's talk about it. Let's get you back into the FQ. So really driving back to primary care and making sure that they have what they need to be managed, or understanding if they have access issues, to getting to the clinician, et cetera, and how we can support them in that, having them understand what their benefits are around that as well. I'm gonna go this way. And then last but not least, I've touched upon this, in several different messaging through the flywheel, and you can sort of see where the flywheel really begins to with getting data, curating data, doing outreach, and then driving folks to the a point of care, driving them into the FQ. What becomes critical is our partnership with VIM, which is our point of care solution. We push into VIM a list of things that the provider can address with the patient, whether it's recently having discharges, or their severity, their acuity, what happened in some of their visits through ICD codes, the diagnosis codes, preventative screenings that need to happen, whether it's breast cancer screenings, colorectal screenings, well child visits, et cetera, immunizations. This allows us to surface at the point of care, in partnership with the provider, what's the next best thing for this patient. And of course, at the end of the day, the providers make their decisions, but it allows them not to go in completely blind, knowing what's happening with this patient. And that's the real value add of this entire ecosystem, which is getting the data and pushing it to the point of care. We do get this data back as well, so we're really able to see patient and provider behavior, and then again, work with patients and providers in a continuous cycle through the rest of this flywheel.